students who take, who are in the course that I co-teach with Diana Surratt called Frontiers of Justice, they do all of the students do a project, a social a policy project. And 7 enterprising students decided that in psychology, we don't know enough about Indigenous studies. And they did a policy proposal that we develop a course, which this hopefully your talk today will lead into, on Indigenous studies. And so I want to thank Andrea is here, and I don't know who else is here from that group, but they have enlightened us. They've left their legacy with the course, and they identified you as one of the premier scholars in social science, and the kind of person that is a role model, but also somebody that we can learn a lot from. So thank you, and we're very grateful that you're here.
Well, thank you. Wow, what a wonderful introduction. It's not often I get such background and generated by student interest. That's fabulous. I'm really excited that this came together and delighted to talk with you today. I'm going to share my screen so I can show you some slides while I talk. And as you are aware, the topic of my presentation today is reimagining mental health services for American Indian communities, centering Indigenous perspectives. So it's going to pick up on the kinds of things that Geraldine already summarized and trace a through line from my career across different research projects to show how I've come to do the work that I do and why I think it's important. And I'll plan to stop talking around the top of the hour so that we have adequate time for exchange. So why don't we go ahead and proceed? Just to introduce myself, I am an academic psychologist. I don't need to say what that means for you. A lot of folks in American society think that means you put people on the couch, and we do a lot of other things besides clinical work. Although I am clinically trained, all of my work is community engaged and of necessity culturally attuned. My research interests lie at the intersection of culture, coloniality, and mental health, because I work and engage with Indigenous communities. And Indigenous communities in their engagement impress upon me the importance of Indigenous psychologies for thinking through some of these issues. And that's especially relevant when it comes to trying to develop cross-cultural interventions that might be of relevance and interest to people in my communities. I have 4 goals today to share with you. The first is to define what I call a post-colonial predicament that vexes mental health services for Indian communities. The second is to consider various community-based approaches that harness, quote, culture as treatment, unquote, for resolving this predicament. The third is to assess the strengths and limitations of these diverse approaches relative to issues of community commensurability. And finally, to grapple with the challenges facing these kinds of projects in the era of professional accountability and evidence-based practice. These are 4 sorts of things that I'll return to at the end to try offer a bit of summary for what we've covered today. Let me start by just defining this key concept that I advanced called the post-colonial predicament. And this arose early in my career with one of my first research projects on my home reservation. The backdrop for this, of course, is that we have in our communities mental health inequities or mental health disparities, which is to say that we have pronounced mental health problems, but the mental health resources, services, and so on that are on offer are often deeply underfunded. They typically are an obligation of the US federal government. It tends to provide services through the Indian Health Service, which is a branch of the US Public Health Service. And then a lot of times those services are taken over directly by tribes. But the point is that the funding is 40 cents on the dollar for a period of time, maybe 60 cents on the dollar now. It's just not adequate to meeting the needs relative to what federal investment in other people's mental health care looks like. So it should seem fairly straightforward. If you've got problems and your services aren't funded, why isn't the solution simply to properly fund the services and expand or ramp them up so they're widely available? But in this early research experience of mine, I came to question whether that was the only solution or the only main way to approach this problem. In fact, I went home to my own reservation, the Fort Belknap Reservation in north central Montana, where I interviewed different people about mental health concerns. Specifically, I was interested in understanding their understanding, not my professional understanding that I have been trained and socialized into, but rather their understanding about the links between culture, drinking, and depression in our community and perhaps in other Indian communities if they saw similarities. In other words, I was adopting a kind of anthropological stance, trying to bracket again my own professional knowledge, and instead in open-ended and discovery-oriented fashion, try to understand what people on the ground were thinking and saying about these things. And I ended up in this project focusing on the work of one individual who in our project together decided to go by his Indian name of Traveling Thunder. And Traveling Thunder had a whole pretty well established and coherent explanatory model for the relationships between culture, drinking, and depression in our community. An explanatory model is one of these medical anthropological terms that talks about the way people in everyday life make sense of, understand the origins and the treatments and the implications of suffering. And so Traveling Thunder's explanatory model really hinged, as we discussed these issues, on 4 different historical periods, 4 historical eras. The first era he talked about was an era that he described as a paradise. It was an era of pre-colonial existence in which he described perfect harmony and balance in Indigenous life, according to him, because of strict observation of custom being the key thing. But of course, that didn't last. Europeans arrived. There was the era of conquest or colonial contact. And he underscored that the main casualty of colonial subjugation for our community was the annihilation of Indigenous custom. So the custom that had things going well was annihilated through colonial contact. That resulted in a third era, which was marked by loss or characterized by post-colonial effects, in which he described a kind of psychological anomie that resulted from colonial subjugation. Anomie means no law or no norms, a loss of identity, purpose, and the sense of who you are, where you belong, and what you're supposed to be doing in life. And it was to this kind of anomie that he attributed pathology. And more importantly, he really explicitly identified what he referred to as the white man system as the pathogen, in this case, as the original pathogenic cause of these kinds of problems. Now, fortunately, Traveling Thunder didn't stop there. He felt that a fourth era began right around 1970 or so, an era of revitalization in which a potential post-colonial remedy might be on offer. And this coincided with the rise of the Red Power movement, the American Indian movement, and a recommitment to looking back to Indigenous tradition and custom, and especially to beginning to practice again ceremonial tradition, sacred tradition that had been subjugated for a long time. And so it was this return to Indigenous, especially sacred custom, that Traveling Thunder identified as really the potential for remedy here in the context of drinking, depression, and culture in our community. So just to unpack a little further here, in terms of Traveling Thunder's explanatory model about the origins of these salient mental health problems in our tribal community, he designated a really clear pathological process. And if we had time, I could show you in his words, it is this sequence: that colonial subjugation results in a kind of cultural repression that then gives rise to psychological anomie, which can lead to substance abuse, depression, worthlessness, and suicide. And of course, these are some of the very problems that seem to be most pronounced when it comes to Indigenous communities. Interestingly, he offered very little elaboration of personal distress. He really wasn't talking at the level of the individual at all. And in fact, he offered a relatively non-biological and non-psychological account of the origins and effects of these conditions. He didn't talk about brain chemistry or genetic predispositions. He didn't talk about family dynamics or psychological defense mechanisms. In fact, he didn't even mention the word trauma, which today, people would often talk about this in terms of historical trauma. Instead, Traveling Thunder emphasized history, culture, and spirituality. So it was really at a kind of different level of explanation that his explanatory model settled. He attributed all of this, as I said, to the white man system, which is to say that he attributed native distress to colonization. That was his main underscored point. In doing so, he emphasized systemic factors more so or over intrapersonal factors As I said, he didn't really talk about individuals that much at all, and not psychology, not biology. Really, his emphasis was on shared community vulnerabilities that all of us might have experienced together. And in many respects, I think this is prefiguring historical trauma and the way that it's come to be talked about throughout Indigenous mental health today. It has the same components of being colonial in origin and collectively experienced, maybe accumulating over time. But interesting, just as a point of bracketing, he didn't mention the word trauma, as I said. He offered a pretty non-psychological account. So trauma is not so much a piece of his take here, although one wonders what he would have said today. Now, if you're like me, learning all of this, you might wonder, what is the relevance of psychosocial helping interventions, mental health services like counseling and therapy and so on? So I put it to Traveling Thunder. I said, well, okay, I understand what you're telling me. So under what conditions would you take a loved one who was going through a really tough time, suffering, deeply, down to the Indian Health Service clinic at Fort Belknap Agency and get them some help from some counselors and therapists there? Well, he grew quiet in response to that and thought soberly for about 10 seconds. And here's what he had to say in response. Quote, I guess it's like a war, but they're not using bullets anymore. They want to wipe us out, and therefore the Indian problem will be gone forever. But they're using a more shrewder way than the old style of bullets. If you look at the big picture, look at your past, your history, where you come from, and you look at your future where the white man's leading you, I guess you could make a choice. Where do I want to end up? And I guess a lot of people want to end up looking good to the white man. Then it'd be a good thing to do. Go to the white psychiatrist in the Indian Health Service and say, well, go ahead and rid me of my history, my past, and brainwash me forever so I can be like a white man. I guess that'd be a choice each individual will have to make. Now, it's clear from this that Traveling Thunder himself was not interested in making that particular choice. And in, describing mental health services in this way, he really pointed to mental health treatment as a cross-cultural encounter for someone like him and other people in our community who are kind of oriented like him. But more importantly, he's got an ideological component that he's pointing out here through this language of brainwashing. That is, it's not just that it's cultural difference. He's recognizing that mental health services might be a form of implicit Western cultural proselytization as well. And I use the term proselytization deliberately here. That has to do with conversion, religious conversion, missionary work. Indian people have had a lot of missionaries in our midst as part of the civilization campaigns of federal policy for a long time. And this kind of cultural proselytization, in a secular format might be kind of, as I sometimes say to my Indian audiences, perhaps we as therapists, Indian therapists, are like the missionaries for a new millennium here. So all of this gives rise then to what I refer to as this post-colonial predicament. And you notice I put the post in parentheses because it's debatable whether all Indigenous communities are in fact post-colonial or still under colonial suppression. The point here is that on one hand, we have quite urgent community needs. Many of our communities are impoverished and high risk settings. We have these documented disparities in mental health status that have been around since research has been going on. On the other hand, the clinical services that are offered to remedy these problems are actually in many instances incongruent with actually being helpful. So this is what Traveling Thunder was talking about when he said that going to white psychiatrists was an invitation to brainwash me forever so I can be like a white man. And this is picked up, obviously, everywhere I go, people talk about this, but also by research in these communities. I think of one piece of work in multiple reservations in the Midwestern United States by Melissa Walls and Les Whitbeck, where they in open-ended fashion asked people on a survey, who would you go to when you have mental health problems or mental health crisis or you're suffering in this way? And mental health professionals don't even make the top 10, So there is a disconnect here that even research has picked up at various times. Okay, so if we have reason, according to Traveling Thunder, to be concerned about mental health services as a remedy for the kind of suffering we witness in our communities, what have tribal communities done in response? Or if tribal communities are able to run and administer their own programs, how is it that they begin to make sense of all of this and try to do something differently? And that's what I want to talk about next, an integrative approach based on work I did in Manitoba, Canada, with a First Nations reserve there that had their own treatment center. Before I go into the details there, again, this post-colonial predicament, invites us to first and foremost recognize that all clinical intervention is inherently cultural prescription. There is no acultural, universal clinical stuff that isn't oriented and embedded in cultural assumptions and foundations. In addition, then, this invites us to acknowledge the hazards, the potential hazards of a kind of neo-colonial proselytization that happens through services in our communities. And so I think we want to take seriously the claim I hear everywhere I go in Indian country from people who are mental health providers or advocates or policymakers in our own tribal nations, that, you know, they say we don't need the latest, greatest evidence-based practice. Our culture is our treatment. That looking back and revitalizing and reclaiming therapeutic traditions that are our own are probably the way to go. And so I think what they're referring to here is the fact that an acknowledgement that therapeutic alternatives based on reclaimed, in many instances, traditional practices are something that would be very beneficial for our peoples. And that these tend to be grounded in a holistic rationale that's much more than, you know, compartmentalization of the biomedical and the psychological. In fact, it tends to centralize and center spiritual and religious experience, as these approaches and practices are often ceremonial and ritualistic. And they're addressed not just to personal distress, although that's obviously important. That's why someone needs therapeutic attention, but it's also addressed to cultural identity, because we're talking about anomie in the model that Traveling Thunder put forward. And so remedying anomie through reversing the longstanding trends of stigmatizing and denigrating Indigenous peoples and their identities is important. And in the end, it is all about community renewal and self-governance, self-determination as well. So when we think about this alternative, our culture is our treatment. It's really a much more holistic approach that does look back, even as it seeks to intervene in ways that are quite broad and contextualized. Back in the early 2000s, I went to this Canadian First Nation Healing Lodge in a reserve in Manitoba. And this Healing Lodge was a substance abuse treatment center run by the tribe. So it was a Western Algonquian tribal nation. The Healing Lodge itself was accountable to the band that administered it. It was staffed entirely by tribal members. I think there might have been two staff who were the same tribe, but not the same band. So, but ethnically, culturally, the same. And it was nationally accredited, which at least at this time, there weren't that many tribally administered programs like this that were fully accredited in this way. It had an inpatient treatment program for addiction, and it had a referral service. I was really focusing on the outpatient substance abuse treatment program. That's what I'll be talking about today. And in particular, the outpatient program was compelling to me because of its commitment to integrating what they referred to then as Western and Aboriginal therapeutic approaches. So I brought a few questions. What does therapeutic practice look like? A descriptive endeavor. What does healing mean here in an elucidating and explicatory approach? And what are the prospects and pitfalls of therapeutic integration in these kinds of settings? What are the implications here? And it was a brief ethnography, a lot of semi-structured interviewing and thematic analysis and so on. So first then, in terms of the question, what does therapeutic practice look like in descriptive terms? Well, as I said, they recognized and categorized Western approaches and Indigenous approaches that were therapeutic. And in terms of the Western approaches, here's what they talked about. First and foremost, it was this 12 steps traditions of Alcoholics Anonymous, which they had great faith in because of its long track record of helping people and because it was spiritual. It had a spiritual component to it that made it really compelling. In addition to this, they were enthusiastic about, open to, and eager to incorporate, to the degree opportunity allowed, a wide range of complementary and alternative treatments, or what we might call today integrative medicine practices. You know, people talked about the 7 sacred chakras. They talked about neuro-linguistic programming, the inner child, you know, basically Reiki. I mean, anything that was complementary alternative, especially with a spiritual component to it, was of wide interest. Did they do all these things? No, but they wanted to, and some of them they tried to apply. So 12 steps with this other stuff also pulled in when possible. There was a complete absence of what we refer to as evidence-based practice, or what used to be called in psychology empirically supported treatments for substance abuse. You know, if you go to NIDA, the National Institute on Drug Abuse and the NIH, or National Institute on Alcohol Abuse and Alcoholism, you know, you can get what are the most rigorously supported interventions for addiction that clinical trials have supported. And you can get a dozen different approaches to treatment, but none of that was of interest here. In fact, I didn't get the idea that people cared at all what science might have to say. Really, it was this appeal of an encompassing spirituality. As I said, it was, you know, quite open as to what kind of spirituality it might be. It's the first time I've ever been in a sweat lodge ceremony where someone gave a little speech about 7 sacred chakras, for example, but, you know, very integrative in even just what they were calling these Western approaches, which, you know, obviously some of them are they're non-Indigenous approaches is probably what best qualifies them for this category. In addition to this, they had Aboriginal approaches. And any of you are familiar with our communities know that these things are often available or integrated into substance abuse treatment. Talking circles, smudging, which is, you know, burning of ceremonial plant medicines for prayer, sweat lodge ceremonies, pipe ceremonies, and fasting camps. Up there in the bush, in the summertime in particular, they could take patients out if they were interested and do fasting camps, or they might seek a vision. These were institutionalized into the treatment program. They actually had a cultural counselor who was responsible for a lot of these things. He ran a sweat lodge on a certain day of the week at a certain time that everyone knew about on a weekly basis. And so, you know, these Aboriginal approaches were part and parcel of actual treatment there. But no one's mandating patients or clients to do this, of course, but it's available. And anytime that any Indigenous community does this sort of thing, there ends up usually being some kind of contestation around whether the cultural practices in question are truly authentic and so on. And that was true here, but it didn't seem to impede the ability to offer a lot of this stuff through formal treatment. So you're probably getting the idea now that there's just widespread interest in lots of different kinds of things that might be therapeutically beneficial to people. And like me, you might wonder, well, how does all this come together into coherent treatment exactly? And the answer to that question was really the treatment philosophy built around the medicine wheel. So a medicine wheel, as you can see on the right here, is a circle bisected by 2 perpendicular lines, creating 4 quadrants. In Indigenous communities, these 4 quadrants are usually accommodated to 4 different parts of a whole, whether it's 4 sacred medicines like sage, sweetgrass, cedar, and tobacco, or whether it's the 4 cardinal directions is often the foundational one. And the basic idea here is that it's a 4-in-1, that there's a holistic integrated thing that has 4 components to it. And so, you know, directional space is really imaged in the medicine wheel because you enter the medicine wheel from the east. That's where the yellow is, and you move south, west, and north in these different ways. And it's also cyclical time because, as I say, you enter in from the east and you trace around the circumference. And so, you know, often these things are signifying time, temporal aspects as well. And so if you take this in a treatment setting, as is very commonly the case both in Canada and the United States, you can apply it then to human psychology in a way that allows you to start thinking about treatment in a way that's self-referential for folks. It provides, if you will, a topography of the self. The 4 constituent parts are mind, body, spirit, and emotion. Sometimes communities will substitute something for the 4th one. Instead of emotion, maybe it's the social, you know, so there is some variation around that. But there are 4 parts of the person. And the idea is that the person is a totality, but illness and dysfunction arise when these 4 components are out of balance. And so the medicine wheel is all about trying to keep in balance in the harmonious totality, the 4 constituent elements. It's also a rendering of the human lifespan. So you enter in the side from infancy, adolescence, adulthood, and elderhood, for example. And you're tracing a cycle again. So you enter helpless as an infant, dependent on others for care. You make your way around the circle of life, and you end up in ancient elderhood, again being totally dependent on other people before you pass out of this world. So really, the medicine wheel philosophy or concept or model became the way that people explained for clients how to work a treatment program. All of those different practices are available. Really, the goal is to keep all 4 constituent parts in harmony and balance. So you need to do that. We're using whatever therapeutic tools we can provide here. All right, finally, secondarily, I was interested in the meaning of healing. So this was a much more kind of ethnographic endeavor because people can tell you some things, but that doesn't mean that you're understanding all that they might more implicitly take healing to mean. So it was engagement in elucidation. So there were explicit meanings of healing. I asked people, what does healing mean to you? And they would tell me. And those kind of things involve this kind of spiritual or existential transformations that link imperfect selves to higher purposes. And also in this setting in particular, a kind of post-colonial reclamation of Indigenous cultural identity. So, selves being transformed and identities being refurbished, if you will. But there were also a very rich discourse about therapeutic practice, particularly from counselors, also from some clients, especially those clients who had really taken this stuff up. Some implicit meanings of healings that no one ever quite set forth in the way I'm presenting here, but which were very clear from how they talked about their healing work. And these implicit meanings of healings consisted of three components: emotional burdens, cathartic expression, and self as project introspection. So emotional burdens are the idea that you carry unexpressed pain from the past. And if you don't do anything about it, it undermines your present day functioning. And so what's necessary to begin to remedy or address these emotional burdens is cathartic expression. That is, you can begin to release this unexpressed pain through verbal expression of past ordeals, which can restore one to wellness. But it's not enough just to begin to release this through verbal expression. You have to then embark on your healing journey. And this journey entails lifelong practices of self-examination, self-awareness, working on oneself, and so on, that is necessary for maintaining wellness. So these were things, again, no one said, here's what healing means, but when they talked about what they were doing as a healing endeavor and how they could gauge whether it was working and so on, these were the ways they talked about it. So you put all this together and you end up with a summary meaning of healing that I described as follows: an ongoing process of positive self-transformation fueled by introspection, reflexivity, insight, disclosure, catharsis, dealing with one's problems, working on oneself, and finding one's purpose as an Aboriginal person that ultimately reorients fragile and often damaged selves toward a more meaningful and compelling engagement in the world. And clearly here there was a very deep commitment to buttressing a robust and healthy Aboriginal identity, and also to really thinking beyond the treatment program proper. This was the outpatient component, which means it works with people who are living in the community. And so bridging the individual client and the community itself was a big commitment of this group. The counselors would go off and do workshops and presentations for community members, engage in some of the Aboriginal treatment approaches and so on with community members in a way to try to collapse the boundary between the community and the client base. So finally, just to circle into the third component of what were some of the implications of this integrative effort for post-colonial remedy. Well, I think what I walked away with was really impressed by the proliferation of what we might refer to as modern therapy culture. The stuff about the unexpressed pain and the burdens, and you've got to, talk in therapy to express these things and then take the self on as a therapeutic project. That comes right off of the self-help bookshelf in any bookstore. That's been a part of modern therapy culture for a long time. It harkens back to Freud. It's kind of a pop psychoanalysis about the need to express one's pain and cathartic. What's important to say is that the staff were really enthusiastic about this, and it's in part because they themselves had experienced these kinds of healing transformations through similar kinds of programs, although a lot of the programs they went to were not Indigenous or Aboriginal focused. So, they were basically trying to indigenize the stuff that they had experienced. And so you've got the integration of the Western and the Aboriginal, even as at its core, it was sort of familiar in terms of this kind of modern therapy culture. The pursuit of cultural commensurability can be tricky. And of course, there was a lot of Aboriginal Indigenous stuff that was clearly being done here. At the same time that, it started to become clear as I was talking with people that they might have had hundreds of clients come through the program, but maybe 15% ever stuck it out through the full 12-week cycle. A lot of people dropped out. Now, that's not uncommon in addiction, so I'm not saying that shows that things were especially dire here. I'm not saying that at all. But what I'm saying is part of what arose in my understanding of these things was that when I talked to clients who had come through, some of whom did finish and some who didn't, the main thing everyone seemed to talk about in my interviews was the importance of talk, or the pressure of having to talk. That the expressive part of this really seemed to take up a lot of people's attention and energy. And clients talked an awful lot about how hard it was to talk, the courage it was required to say these things in the therapeutic group, and counselors encouraging them to talk, but the struggle around that. And I want to suggest here that it's possible, based on anthropological ethnographic work with other Cree communities, for example, that there are a whole set of cultural norms that govern Indigenous communication in face-to-face reserve and reservation communities that don't look a lot like modern therapeutic expressivity. And in particular, people's identities are tied up in family reputations, and there can be rivalries between families for status through reputation. So public talk is often regulated very, very carefully. I'm not talking about with intimates now, but without where you can't control who knows and where it's going to travel through gossip or the moccasin grapevine or what have you. So I think that, communication was one of the potential areas where modern therapy culture actually might have tripped up the opportunity to involve more clients. And that wouldn't be true just here. That's true anywhere that there's counselor therapeutic activity happening that has any kind of, public facing or lack of confidentiality. In any case, this whole project led me to want to consider that maybe we need to think through core periphery kinds of arrangements here. I would say that this had the kind of modern therapy culture self-help sort of ideology at its core, and it was wrapped in kind of Indigenous and Aboriginal approaches. But what would happen if we inverted that is what I wondered. And so that's what took me to my next set of projects. Okay, I'm gonna speed us along a little bit here through this next round. Here is the approach that I was interested next, which was to move beyond the usual approach for how cultural adaptation of treatment happens. That usual approach is to start with a mainstream intervention, preferably an evidence-based or empirically supported intervention, and figure out how to secondarily adapt that for use in diverse community-based mental health services. But what I wanted to know was, how would it happen if you switched that around? If you inverted that relationship, the core periphery that I just talked about? What if you started with Indigenous therapeutic traditions and then secondarily figured out how to cultivate those for use in community-based mental health services? But to really explore this, I needed to find a community that was interested in looking at this. And so let me just say that I ended up approaching the Crystal Creek Lodge in Browning, Montana on the Blackfeet Nation. And the Crystal Creek Lodge is the addiction treatment program in the Blackfeet Nation. And I approached the staff in the spring of 2008 just to say, look, right now you do a Hazelden model group-based addiction treatment approach for inpatients and outpatients. That's very similar to what you can find other places. And you do have a cultural counselor with some cultural groups, but mainly it's a 12 steps based program. What would happen? What would be your interest in exploring what would happen if you started with Blackfeet therapeutic tradition, whatever that means, and were to try build a program for addiction clients in that way? And how open would you be to trying to explore this scientifically so that we could try to chart a little better what would happen to folks over time? Well, they got very excited about that, in fact. And so we started a more extended deliberation in August of 2009, the goal of which was to begin formulating what would this Blackfeet treatment model look like? How would we put it together? What shape would it take? Who would administer it? And how could clients expect to benefit? And the cultural counselor at the time was plugged in to the network of Blackfeet religious revitalizationists there on the reservation. And so we ended up consulting some of the Blackfeet bundle keepers, ceremonial bundle keepers who keep their religious practices alive. And he in fact was a member of this traditionalist crazy dog society. So he enlisted their help. And that's how we got to formulate this Blackfeet treatment model. It was traditional people who were engaged in Blackfeet ceremonial practices who guided and directed for what shape this should take. In the end, we developed this radically alternative treatment model. It was basically a summer cultural immersion camp designed to help Blackfeet clients live something like their pre-reservation ancestors might have lived. Teepees and living off the land and going to visit sacred sites and so on. I'll show you the components in a moment. It was facilitated by members of the Crazy Dog Society. Again, this group of Blackfeet ceremonialists who were trying to keep alive the old Blackfeet religion. And so socializing clients into aspects of this old Blackfeet religion was sort of the rationale here, although it wasn't heavy-handed, it wasn't, like missionary work exactly. It was more like indirect in many respects. But I think that's because the actual underlying rationale is that healing and recovery come from spiritual practices, ceremonial practices that circulate life. And it's life that, once in circulation, can overcome despair, disease, infirmity, dysfunction, disability, and that sort of thing. And these are religious ideas and religious approaches, actually, that undergirded this treatment model. So we piloted it in the summer of 2012, just as a proof of concept. I mean, you work, you develop, you blueprint, you have no idea if anyone can pull this off, if any clients would come, what their experience would be like. So it was sponsored by the Crystal Creek Lodge. I was able to contribute some funds, but they were committed enough that they allocated a lot of their own funds. It was staffed by Crazy Dog Society members, not by addiction treatment counselors, although obviously the addiction program had an obligation to take care of clients. So there were people on site and so on, but it was not staffed by them. And, we had 4 intrepid guys who were willing to try this for 2 weeks just to see how it would work. In Indian country, it's often the case that people don't want to be the guinea pigs. They want to wait and see and hear how things went before they get involved. So in terms of what this camp involved, there were 3 categories of activity: traditional skills, cultural practices, and ritual participation. The idea was every day the Crazy Dogs would have a schedule for something that we would do. And it would be, these kinds of things. For example, on the first day, we set up camp. So, learning how to pitch teepee is something that you actually have to learn how to do. And we put up a double teepee for meeting for the lodge that people would gather in, and that was extra complicated. And then ended it all with a pipe ceremony, prayer ceremony to sort of get things going. So there would be days of things like that, and the Crazy Dogs are responsible for deciding what it would be. And these were the different things: the traditional skills, the teepee setup. The Blackfeet have a long tradition of painting their lodges in very beautiful particular ways, picking berries, harvesting sacred plants, tanning hides, collecting a niskim, thunderstones, buffalo stones. These are sacred, they're fossilized ammonites, but they're understood to be sacred by many Northern Plains peoples. Cultural practices like storytelling, tracing your family ancestry, visiting sacred sites. In Glacier National Park, which is adjacent to the Blackfeet Nation and actually was Blackfeet territory prior to the park being established, Chief Mountain is the most sacred site to the Blackfeet, and that's there. Decision-making exercise was part of this. And then ritual participation, talking circles, pipe ceremonies. On the second day, we went out into the bush and created a sweat lodge and had a sweat lodge ceremony, for example. And the Crazy Dogs have some of their own private ceremonies and involving clients, and that was part of what we did as well. The ethos of the camp is really important to track here because I think it contrasted pretty markedly with the addiction treatment as usual here in the program. First of all, it was leisurely paced. It got going when everyone was ready to get going. If someone had to go back in to get a shower and come back out, it was fine to wait for them. And it ended when it ended. If it was after dark, okay. If it was at 5 o'clock in the afternoon, okay. And so it was responsive to the orders of the day in many respects. It was loosely scripted. So you need some kind of structure, right? Or things don't necessarily happen, but it wasn't tightly structured, loosely structured. I remember the Crazy Dogs had hoped that we could actually hunt a buffalo one day. And the permissions didn't come through from the council or whatever. So we had to do something else that day and they were ready to go. It was seamless, no problem. So loosely scripting was useful. It was sensitively guided. This is really important. I think in some of our Indigenous communities, our traditional practitioners can be quite rigid. My way or the highway, there's one right way, it's my way, and the leaders of this were not like that at all. They were so understanding and compassionate and funny and tender, really, with clients, that it was just fantastically done in a way that's a model, I think, for how this kind of work can be done. And if it wasn't like that, I do wonder how well clients would fare. It was monitored by the treatment staff. It had to be because there's legal obligations and so on. But again, it wasn't run by them. And then it was community engaged. So the Crazy Dogs is kind of this group of, I don't know if it was 40, 50, 60 people. People would come on whatever day they could, and we'd go off and do an activity, and you'd see 30 people wandering around the hill together doing this activity. people didn't even know who the clients were and who the crazy dogs were. I mean, there was no dividing line really, and no need for a dividing line in terms of some of this kind of activity. So really engaged in important respects. In terms of its enduring impressions, this was really memorable and inspiring. I mean, it would be hard to overstate the sacred and socio-political significance of this kind of endeavor. It was completely unrecognizable as psychosocial treatment in terms of anything that probably is harnessed and labeled as addiction treatment in the United States. It was centered on traditional spirituality and religious experience. That wasn't all we did, but there was always that component, and those were the touch points and the anchor points. It promoted the genuine sense of community and belonging, as I said, in ways that didn't even differentiate between clients and other people. And it was valued by the clients. Of course, I wanted to find out, so I did post-camp interviews, and that you take that with a grain of salt. But people did. I have things that they suggested for improving it. So people were willing to be critical about it at the same time that they acknowledged they very much valued it. I think this experience raises some really crucial questions that are important to note. So what we weren't able to do, of course, was to follow these folks up. In fact, it didn't really go in terms of a research project past that first summer. So there are empirical questions. Can processes linking culture and recovery in Native communities be harnessed and deployed as treatment? And is cultural immersion of this sort really intensive enough to remedy substance abuse across a range of addiction severity? We don't have answers to those questions. That would be a multi-year research project where you have to follow people for quite a while. There are logistical questions. Can scientific evaluation of culture as treatment projects of this sort overcome some serious limitations like small sample sizes, constraints on random assignment? I mean, if this is a sacred engagement, there's only a subset of people who are probably interested enough to even do it. And so how do you contend with those sorts of things? Can development, implementation, and evaluation of culture as treatment projects compete for research funding, like big money? I'm not sure that it can. It's pretty outside of the box. And, so that's a question and a concern with respect to these sorts of things. But what's also important to say is that this was so important to the Blackfeet Crystal Creek Lodge that they offered this in consecutive summers on their own with their own money, refining, amplifying it, bringing, there were a lot more people involved in subsequent summers as word got around. And so this became something that they valued a great deal, so much so that they carried off, even though I wasn't really involved after that first summer. And I think it leads us to an important question that we want to face head on. What if there are irreducible trade-offs between, on the one hand, development of community-driven post-colonial interventions, something like this, and on the other hand, design of portable, replicable, and scientifically evaluable interventions? What if our commitment to evidence-based practice actually gets in the way of our ability to work with partners to do things outside of the box, off the beaten path, that actually they find very valuable and is actually therapeutic for people in this way? Okay. So I'm mindful of time and don't want to overstep our opportunity to exchange. So let me just briefly review. Those questions about portability, replicability, evaluation were of interest to me. And so the next project I undertook, which I will not take the time to go into detail, I should say each of these sections are their own standalone presentations. So, there's a lot more to be said about all of these, but let me just briefly canvass this last segment, because in this last bit, it was my effort, okay, what could we do that might be a little more portable across different Indigenous communities that's not so tailored to an individual community that it wouldn't necessarily work other places. And so I entered into a research partnership with the Urban American Indian Health Clinic in Detroit. It's called American Indian Health and Family Services. They receive IHS funding and lots of other funding to serve the Indian community in Detroit. And they invited me really to think about how could they best incorporate traditional healing practices into clinic programming. This became a multi-stage project. There's different things we've written along the way, but first was about a year of consultation with community members, with staff, with administrators, with traditional healers, to try just get an answer to the question of what is the best way to incorporate traditional healing into health services in a clinic setting. And then we engaged in program development once the administration sort of gave us marching directions. They said they wanted a program that would orient community members in the Detroit urban Indian community to Indigenous traditional spirituality at its most basic level? Can you orient them to that? That was the question. So we worked on a couple years developing what that would look like, and then we had a chance to implement it. And so that's what I'll briefly canvas here. Just the who, what, where, when, why, and how of the Urban American Indian Traditional Spirituality Program. Who? It was for any adult members of the urban Detroit American Indian community, especially who had never been had experience with Indigenous traditional ceremonial practices before. What was it? Well, it was a structured orientation to Indigenous spiritual practices. In some ways, I thought of, at one point in my life, I went through Roman Catholic confirmation, where you go through classes. In some ways, it was a bit like that. How this was a sort of like a catechism, but for Indigenous traditional spirituality. Where? At the Urban Indian Health Clinic itself. When? It was a 12-week program with one session each Saturday for 3 hours at a time. Why? Because the rationale or logic here was that it could be beneficial in all kinds of ways, but including in ways that are about good health, to help people inaugurate spiritual devotional life for the participants of this community in a way that could enhance wellness outcomes. How? Through socialized participation in the sweat lodge ritual. So we settled on the sweat lodge ceremony as the main focus of this traditional spirituality curriculum, because first of all, the sweat lodge is pretty much everywhere you go in Indian country. It didn't used to be everywhere, but it is now. It's kind of pan-Indian in the sense that everyone has a version of it, but the versions are distinctive. And in this case, the version on offer was by the people who could run the sweat for this particular setting. So that would be the sweat that we followed here. The program structure, as I said, was 12 sessions. There was an orientation. There were 4 sessions of teachings, then an actual sweat lodge ceremony, then 4 sessions of teachings, which were kind of reinforced and rehearsed some of the stuff from before, then another sweat lodge ceremony, and then a community gathering that became kind of like a graduation. People actually used the language of classes to refer to this. So it became like an educational endeavor, more so than like you would think of like a religious or church endeavor, which was interesting to me. Here you can see some of the components. I'll just let you look that over for 15 seconds. We were very committed to not assuming anything on part of the participants. We really wanted to start, what is prayer? How do you pray? Who are you praying to? Those kinds of questions, because otherwise people who don't know those things can start to feel alienated if they're, seen to be like unsocialized or something in these things, and we didn't want that. I put drugs and alcohol abuse here in red because it's the only piece of this program that had anything like public health messaging or mental health behavioral health treatment messaging. And it was simply because ceremonial participation is usually understood to be incompatible with drug and alcohol use and abuse. You're said you have to swear off those things for at least 4 days before a ceremony for most communities. And so it just isn't incompatible. So it gave an opportunity to say, look, if you feel like you might have a problem, you could go see these folks in the clinic, so it was an opportunity to do that. Otherwise, as you can see, this was not really conventional treatment language or approach. And we had targeted wellness outcomes that we thought would make sense to respond potentially to participation. Enhanced identity, spirituality, ceremonial knowledge, culture, and involvement. Let's certainly hope so, right? Increased community mindedness, coping skills, social support, help-seeking attitudes, and greater life satisfaction, reduced distress or symptoms of distress, and improved emotion regulation. So, we had measures that we did use in this pilot, but of course the numbers aren't enough to really do too much with. But really, this was the proof of concept again, just to pull it off. And then to think about, okay, now how do you refine it in light of participant experiences? And we did interviews, and we've got a manuscript that's in press right now that reports all of the outcomes from the interviews now. What about funding? Like, could you get a project funded where you could enlist urban Indian communities in other parts of the Midwest, for example, like Chicago or Minneapolis or Milwaukee? You can start to imagine multi-site places where this could happen, and then that might give enough of a sample size to do some evaluation as well. So there's future promise with this, but my point was to say that the Blackfeet camp was really tailored to a particular community. This approach, this curriculum actually has some portability, I think, because of drawing on the sweat lodge, which is so common and throughout. All right, I want to wind down with just some take-home points, and then we'll pause for exchange. Community mental health services for American Indians are vexed by a post-colonial predicament. Real unmet need and services that are incongruent. Professional and indigenous therapeutic traditions diverge in substantial cultural ways. These really are quite different approaches with different therapeutic rationales. There is broad interest in indigenous communities in reformulating services toward greater cultural commensurability, particularly with respect to looking back to tradition. And so a compelling point of departure is the indigenous claim that, quote, our culture is our treatment. And these culture as treatment projects can depart somewhat substantially from what is otherwise recognizable as a form of psychosocial intervention or helping service. There could be interest, of course, in trying to evaluate these scientifically, and I certainly encourage it. I do think that these kinds of projects have some limitations sometimes that make this a worthy but fraught endeavor. So not always easy to do. On that note, let me say that I've written about a lot of this stuff and a lot of other related stuff. This is my website. It has almost all of my publications available for download at the click of a mouse if you want to read more. Incidentally, my last name is gone. It comes from my great-grandfather who was sent to a boarding school where they took his stepfather's name as a surname. His stepfather's name was Gone to War. So they just clipped it to Gone. He became Fred Gone. Anyway, that's why my website is Gone to War, even though my name is gone. Thanks. I'm really delighted to hear your reactions. I'll stop sharing my screen now and see if I can't get us back to opportunity to exchange. Thank you.
Thank you.
Thank you so much for that incredible talk. Geraldine, any words before we open up Q&A?
So it was all that I hoped it would be. and I've learned so much, as I always have, when I read your work and when I came across you first. And so what I want to do is acknowledge both Andrea and Evelyn is here as well. And there were two, Andrea had mentioned already, but two of the group who read your work and identified you as the person that we must invite. But with that, I want to turn it over to Anna, who is going to moderate the discussion.
Great, thank you so much. And we have our first question from Ray, Dr. Ray Silver.
I thank you very, very much for that talk. I'm incredibly struck by something I've been working on with a hospital in Jaesang Hospital in South Korea, where in South Korea, 86% of the population uses traditional medicine, even though they have full access to Western medicine. And there are two lines for medical doctors, one in the traditional medical field and one in the Western medical field. And it's so interesting that the parameters that enter into their traditional medicine treatment are, they look mechanistically different, but they sort of tackle the same kind of local, cultural, spiritual values. So I really appreciated hearing from you, and I will share your progress and ideas with the group in Jaesang Hospital in Korea, and perhaps one day you can coordinate your thoughts and efforts. Thank you.
Well, thank you for that. That's really inspiring. And yes, this is a global endeavor to work out how services can be made more relevant and more therapeutically beneficial and more accessible. And of course, it takes its own shape everywhere you go, but there are some common elements that seem to arise everywhere.
Thank you, Miriam.
Thank you so much for the talk. I learned a ton, and I found it really inspiring to think through this different lens. And in particular, I was thinking of the last two parts of your talk and how you're saying there's like a blending of the clients and the community and how these are really community-based approaches. So I was wondering whether you think these approaches should be treatments for people who have experienced hardship, or if it's better to conceptualize them as a preventative approach that's taken all the time for everybody, regardless of need or hardship. So which one of those do you think is the approach that would be most beneficial?
Yeah, it's a great question. You know, as I was out with the Blackfeet folks, with the crazy dogs, walking the hills as we were doing different activities, I overheard some crazy dogs saying, this isn't treatment. This is what every Blackfeet person needs. We should invite anyone who wants to come to this, that should be involved. And so, there's recognition, I think, that this would be good, not necessarily confined to the frame of treatment. Here's what I think is at stake by only calling it prevention, however, which is that prevention is often accepted within the health science world as being amenable to a lot of different things that just keep you out of trouble if you're a young person, for example, in forming, maladaptive peer networks and all the ways and languages that we use to talk about that sort of thing. But treatment is often a domain in which these sorts of things are tightened down. We talk about evidence-based practice and clinical treatment guidelines that in behavioral health, where there's really a hard drive to standardizing what clinicians do with clients in therapy. And I've been involved in some of that work myself. I get really impressed by all of the research that has accrued in support of, say, cognitive therapies for a whole bunch of different problems that people can have. And I'm not against it. I think if clients are interested and open to that, we should offer that. And maybe even persuade other clients to give it a chance if they're a little skeptical, to explain it to them. At the same time, that just isn't going to cut it for a lot of people. And in Indigenous communities, I think it's a real swath of people who are oriented more like Traveling Thunder and who are not interested in subscribing to that kind of approach. And the question is, what can we do in that context in the name of treatment? Because treatment is its own world, its own financing, its own sector, its own status and prestige, its own, kind of professional guild politics. And so I have no objection to thinking of culture as prevention as well, and indeed would be the first to acknowledge that is true of all of these sorts of things, even as I think there's something worth fighting for in the domain of treatment.
Thank you. Let's go to Nim, and then we have something in the chat.
Hi, thank you so much for a really rich, wonderful talk. I was most moved by your rich description of the approach to the treatment, and it helped me get an initial view of what that experience must be like. And it got me wondering, as you're talking about thoughts of how do we implement this in other locations, it got me wondering, it seemed like there was such an organic component to that, I think it was 3 days that you described. And so I'm wondering what your thoughts are about how do you recreate that organic component on a larger scale or in different locations? What are the challenges or solutions you've thought of?
Yeah, I think it does speak to the importance of a participatory approach to developing or refashioning, treatment in treatment settings. I'm sorry to say that I don't see that a workaday clinician whose income is generated by therapy hours and billing insurance companies is in a position to do that. So I think that there are real constraints that come with our health services delivery system. I think, though, that with the right evidence, some of those systems might be willing to create, I don't know if it would be a department or a bureau of innovation, where there might be opportunity to not just spend your workaday hours meeting client one after the other doing, your stock therapeutic stuff, but instead trying to figure out how to refine, repackage, refashion the therapeutic in ways that would reach more people with bigger impact. I think we all acknowledge that individual therapy is very costly. And at the same time, one doesn't want to play into neoliberal commitments here around the market driving everything as some kind of unevaluated good. At the same time, that there's not enough to go around. So we've got to start thinking about a different approach that doesn't involve, especially doctorally trained people doing one-on-one therapy. In my own profession, psychology, there's been 50 years of research that doesn't really find that having a doctorate makes you a more effective therapist, So probably we shouldn't be paying at the doctoral level for therapy if there's no evidence that it makes you better at it. And it opens the door, raises the question of, what can paraprofessionals do at the level of behavioral and mental health? So my colleague at Harvard Medical School in the Department of Global Health and Social Medicine here, Vikram Patel, is very active in India and other parts of the world. And he's proven in these really resource constrained settings, you can train paraprofessionals to do the basics of psychotherapy and mental health management. And the question is, can we overcome guild politics and state licensure, laws and that kind of thing to figure out how to do something like that in low resource settings in America? In Alaska, there's already a community health aides program where it's dental and medical and behavioral health aides who are paraprofessionals with some training to do some of this. How could we, build on that to make mental health resources much more widely available when they cost so much and the allocations are so limited when it's organized around doctoral level providers?
I wonder if Andrea or Evelyn have a question.
I had a question, but you sort of just answered it. Thank you again for being here. I just have to say you are the fastest person to respond to emails, which is incredible. And we're so happy that you're here. My question sort of revolved around, I live in a First Nations territory in Canada, and one of the schools in one of the nations was saying how, they need more mental health professionals, and it doesn't matter if you're white, if you're not, from a Hausat or Heshquit or whatever First Nations, they just desperately need mental health professionals. And all of my friends who are mental health professionals are very apprehensive because it's very isolating for them to live in an off-grid community, and they don't want to feel neo-colonial and go in there and tell them what to do, even though they are trained in grief workshops, or even Francis Weller talks a lot about this, and he's very aware of these things. I was just wondering what your opinion is on that, as being part of both worlds, I guess. Yeah,
right. Well, first of all, it's nice to see your face, and thanks for your role in making this happen. That's very exciting. You said something very important at the beginning, which is that the communities themselves are, clamoring for more help, and it sounds like they're saying, it's fine that you're not Native. We need more help. Please come help. Well, that's the first thing to attend to. It's hard to go someplace that you're not invited and to take on a role that no one values and to do something that no one cares about. But this does not sound like what's happening there. So I recognize and understand the concerns about, remote community and isolation. But the funny thing is that these communities are not necessarily remote or isolated for people who are at home there. So I think it depends a little bit on your frame of reference and what you expect might happen, or what you're willing to do to not be isolated and feel, So I will admit that I think it takes time for people to come to trust outsiders and small face-to-face communities like most Native reserves. But people do come to be trusted. They do get taken and they become relatives, basically, as someone will make you a relative, then you become a part of that family. And then honestly, I think that's what's required probably to be a really good therapist in a community like that, is to enter into a kind of kinship relationship with people. Again, they invite you. It's nothing you can mandate. They invite you or they don't, but they would invite you based on your disposition. And if you're out there in the community, visible in ways that aren't just hiding in your office and going home far away where you never venture out at night and feel isolated and alone, So I think there are ways to finesse this, but I do think maybe not every person can do it. Maybe not every therapist can do it. It does take a certain sensibility and a certain openness and a certain willingness to kind of bracket one's expertise and to really take on a learning hat in that uncomfortable space where you're also expected and paid to do stuff. Like you're supposed to help. So, you're the helper and people will look to you for help, even if the help you have in mind is you're not so confident in, you don't know how well it applies, you weren't trained for work in this kind of community, so it's an awkward space, I will allow, but I think that there's opportunity for real transformational contributions in that kind of opportunity.
Thank you so much.
Thank you. And we have a question from Sophia Pollock, who asks, what are some measurement strategies to evaluate the efficacy of or effectiveness of some of these alternative treatments, whether through interviews, but also what might be other strategies that you might envision for these efforts?
Yeah, so I think across, what's called the hierarchy of evidence and evidence-based practice, there's a lot of different strategies you can take that will bolster differential amounts of confidence in, causal confidence that a treatment has yielded a particular therapeutic benefit. At the top is the randomized controlled trial, of course, which requires tight experimental controls and pretty artificial conditions and close monitoring. And of course, one's not enough. You would need several of these because you want evidence to accumulate over time. That's not very realistic for the kinds of things I've experienced myself. It might be more realistic in other instances, but it's probably telling that when it comes to American Indian or Alaska Native behavioral health, there's probably only been 5 randomized controlled trials of anything, and they're not replications of the same, kind of approach. So it's hard to get to that. So somewhere between, tightly controlled experimentation with random assignment to treatment and control, and between doing nothing, not even asking the client if they liked it or felt better because of it, there's a lot of room for things. So I think, symptom checklists over time could be useful, and you can chart and profile those. You can certainly do interviews to try to, in open-ended fashion, unpack from clients or patients, things that a survey is not going to tell you so easily, but, surveys can tell you good things. So there's surveys about mental health services, satisfaction with mental health services you could draw on. For addiction in particular, people are not often considered stably recovered from addiction for 5 or 6 years. So, to really track outcomes on addiction, you have to follow people up for a very long period of time. It's very rare that actually happens. So there are just real world constraints in any setting about the logistics of how to assess outcomes. But, simply caring about outcomes and trying to track what you can and asking questions and trying to do the best that is possible under those circumstances to chart what you can seems really important. And I think there's a world of tools out there. It's really a question of which tools fit best, which are feasible in a setting. And in any kind of Indigenous setting, that's all a participatory project in itself. It's, do you have community advisors who can help guide the work that you're doing? Can you explain the different evaluative measures for them? Can they, they will want to pick and have input on what makes sense and what doesn't. They will guide as to what will work the best. But the result is, because it's so process intensive and because the feasibility is challenging and the numbers are small, the reality is we don't have really much outcome evidence for any therapeutic endeavor in any Indigenous community.
So can I push you a little on this? Because I think that this is for any of us who are doing work out in the world, and that this question of how we show it works or in what ways it works is a real dilemma. We're being pushed to do it. We're not getting funded unless we do it. And we know in general it's like nonsense. And it's so, as a discipline, and you as a leader in this discipline, what are you doing about making change that recognizes reality?
Yeah.
Or what should we be doing? That's
well, those are 2 different questions, because the truth is that in the United States, American Indian, Alaska Native communities are semi-sovereign peoples. Mm-hmm. Who have self-governance and do their own taxes, control their own membership, control their own territories. And so there's a mechanism by which tribes can take federal dollars for programs and administer them themselves. And that allows tribes to do some innovative things, in a way that's not possible almost anywhere in healthcare in the United States, is that tribes can innovate. And this really started in, the 1980s around addiction treatment. So addiction treatment's the place in tribal communities to really look for where the most signature innovations are happening. There's been sweat lodges incorporated to addiction treatment programs. I think 40% of programs in a 1986 study had those. So if we think since then, it's probably grown quite a lot. So there's a really distinctive, unique opportunity to innovate in these ways in tribal settings, particularly when tribes control the resources, even when the resources are federal. Now, when it comes to getting NIH funding or even SAMHSA funding, the other thing is that sometimes tribes are not particularly interested in outcome evidence. You know, I think a lot of people think, well, we don't have enough services here. We feel like we already know what to do. We know a culture is treatment or whatever they have in mind to do. I don't know that a lot of folks like to see scarce dollars go to research, you know? So often a lot of tribes will say, or a lot of tribal partners will not be interested in that. And in fact, start to use the kind of government to government leverage they possess as sovereign nations to really say, look, we don't care if you're convinced. You have a trust obligation to the well-being of our people. We are a sovereign nation. You need to fund us to do what we care to do. And that works sometimes. Not every time and not in all instances, but it works sometimes. So, you know, there are ways in which you could just route around all of the concerns of the scientific skepticism and so on. Even as a scientist, I think that there are grounds to be skeptical in some instances and in ways that all of us have been socialized to be. And in fact, in Indian communities, there's skepticism around therapeutic claims. People aren't completely gullible. You know, one family's medicine man is another family's charlatan in some of our communities. So skepticism around health claims is possible. You know, it's sort of about engaging in conversations around when is skepticism helpful and makes sense and adaptive and useful, and when isn't it? And that's the same question actually we have to have among our own scientific community, because there could be, you know, you could be so skeptical that you could be a nihilist and believe there's no knowing anything, you know, but we don't do that. At least I hope we don't. If people really believe that, then all of this is just chasing money and building careers, and that starts to seem too cynical to me.
So do you want to give us one last word of advice about how to get to this as scientists or researchers or social scientists? How do we think about being true to the truth and doing it in a way that's true to reality, to the communities, to what we're trying to do here, which is improve health? And
it's hard to make a prescription that's widespread, because I feel like I was told very early on in my career, look, that's all well and good, but if you want to get tenure here, don't do any of that till much, much later. And I had to go back home and make a decision. What kind of career do I want? And what will it mean if I don't get tenure in this department or this institution? If I don't, you know, listen to what they're saying and try to follow my own way. And I'm someone who, you know, for probably a whole bunch of fortunate circumstances, including great advocates and supporters and people who invested in my work, it worked out. It's a little hard to tell people to do that when you know it often doesn't work out, right? So it's a little hard to know how to answer that question, because my answer, at least for myself, was, you know, I'd rather not get tenure. I'd rather not be a successful academic if it means compromising that much. And it worked out okay, so I'm okay. But I don't know if that's a good advice or not. so you've been around a lot more than I, particularly in departments like social science departments. So
that's exactly the advice I give. So
okay, very good.
So we just want to thank you so much. I know this was your sabbatical and you took your time out to come and talk with us, and you've really changed hearts and minds and science by coming via Zoom to talk to us. So thank you so much, and thank everybody who helped make this possible.
It's been a lot of fun. I'm really grateful, and thanks so much.
Follow up. Okay.
I look forward to seeing you in person again one day.
Yes.